We can start, sir.
Who will be starting?
Yeah, yes, sir.
I should start?
Yeah, just a moment, sir.
Huh.
My screen, is it visible?
Yes, yes.
Yes, sir. Yes.
So my name is Vyas. Can we start now?
Yes, sir.
Yes, sir. It's already on live, sir. Please go ahead.
Yeah. Good evening, respected speakers, Dr. Swapna Sebastian and Dr. Ashwini Kulkarni, our beloved speakers on the occasion of Vibrosummit Autism Summit webinar. I also extend a warm welcome to our chairperson, Dr. Shabina Ahmed Madam from Guwahati. I'm also happy to extend a warm welcome to our medical director, Dr. Babujar sir, and also my colleagues. Thank you so much for accepting our invitation to be present in this webinar. So I wish you a very successful deliberation on the given topic for discussion. So before I hand over the floor to Dr. Babujar sir, I would like to take a few minutes with your permission. There are lots of questions ahead, asked by all of us about our company profile and what we are up to in the Indian pharma market. I just would like to give a fleeting glimpse of what we are trying to do in the last 1 or 1.5 years. So this is, of course, the invitation for today's program. So we are a key stakeholder as far as neurodevelopmental disorders are concerned. And we believe in, we want to create a consensus or shape up the opinion in the management of autism spectrum disorders by holding this kind of summit meetings. The series of meetings will culminate into a major meeting in April 2024. That's how we have envisaged and planned. As a stakeholder, it's our responsibility to spread the awareness of neurodevelopmental disorders, especially autism. And on our part, we have also undertaken many activities to spread awareness, affirmative action, and advocacy. We have brought out digital messages continuously, syndicated columns on autism in leading newspapers, and also awareness through FM radio participation, bringing out calendars to increase the awareness on autism, facilitating child development centers amongst the pediatricians who are interested in taking up this as a career, conducting webinars like this, what we are having today, assisting doctors in public awareness program, and also working on value-added services that we can offer to the society and to the medical fraternity, and also through our various innovative brand offerings. So our first webinar was addressed by our beloved Professor M.K.C. Nair in June, father of developmental pediatrics, and also followed by an equally competent Dr. Samir Dalwai from Mumbai in the month of July. And now we are having the third webinar in the series. So we want to be pioneers in neurotherapeutic nutrition space, and this we want to achieve by bringing novel concepts, unique formulations, and first of its kind initiatives, which is patient-centered. As of now, we are actively involved with these medical societies in our academic pursuits. We are also very seriously collaborating into research side with various institutions like SCARF, wherein we are evaluating the efficacy and safety of psychobiotics. Psychobiotics itself is a revolution in neurodevelopmental disorder market. We have also teamed up with Professor Shilpa Kulkarni Madam of BJ Wadia to assess the efficacy of psychobiotics in autism spectrum disorders. And also, when it comes to AIMS New Delhi, we are also actively working along with Shefali Gulati Madam to identify specific strains for clinical assessment in managing pediatric seizures, and also in association with the R&D lab at Hyderabad. We are also associated with various medical association bodies in bringing out this prestigious journals like Child Neuron, and also a guideline on management of pediatric epilepsy, which is edited by none other than Dr. Shefali Gulati Madam, and also upgraded parenting and child development guide by Dr. Sivaprakasam sir from Tamil Nadu. We are the first one to bring an authoritative book on magnesium from the University of Adelaide. This gives a lot of information about magnesium and its use in neurodevelopmental disorders. We also recently hosted an independent symposium on gut-brain axis in the Regional Congress of World Psychiatry Association, Kolkata, which was well attended. Currently, we are actively doing a CMS with these bodies, that is British Pediatric Neurology Association and AOPN and AOCN, and also RACE TOT workshops. So summing up all these things, we have done close to 40 CMEs during this year in associating with these bodies. We are also on to music therapies to identify specific ragas, which will be very useful in alleviating the symptoms for the patient who are mentally ill patients, and also patients who are suffering from various types of neurodevelopmental disorders. So these are some of the ragas which we have identified. Our work is also nearing completion on this project. I will just play a small sampler for autism. It runs for a few seconds. And this is our brand offering. We have Vibrocar, which works on cognitive domains, IQ-norm combination of DHA and EPA for improving IQ and functional skills. And Lactobrain is a psychobiotic, a promising therapy for neurodevelopmental disorders. Crepsomag activated magnesium for neuromuscular disorders. Histafor for increasing cerebral oxygenation. And Attensure, which strikes a fine balance between neurostimulation and sleep cycle. And Epigly, dimethylglycine, which resolves seizure and comorbidities and improves quality of life. First time, something which works on the glycinergic and neurotransmitter system. Of course, Noctural is melatonin, the neurohormone that works beyond sleep. Apart from this, we are also working on new entities to manage the core symptoms of autism and other neurodevelopmental disorders. So with this, thank you so much. And I now hand over the session to Dr. Babujar, sir.
Good evening. Good evening. Welcome you to this program. And we have got three important people working in this area. Dr. Swapna Sebastian, Professor of Speech Pathology and Audiology, CMC Vellore, and Dr. Ashwini Kulkarni, Senior Developmental Pediatrician from Pune. And our chairperson is Madam. Madam, welcome you to this program. Madam knows, many people knows Madam, but I should say that she is the pioneer person in India in the area of growth and development. And nothing more to say about Madam, because she, while we were students, also Madam was the first person working in this field. Welcome, Madam.
Yeah, thank you. Thank you very much.
Okay. Then Madam can introduce the other beloved speakers.
Okay, thank you very much for this invitation. And I must say that I was delighted to hear Vibrianica's efforts in creating the awareness, autism awareness, advocacy, and the continuous efforts that you are making in bringing in value-added service for the children of autism. And that's very, very encouraging. And today's summit that you have arranged and the topic on the social communication is indeed a very important topic, because we have a group of children who are being identified by this a problem, but are we doing justice to them is what we are all working on it. Everybody have put their hands and trying to build up, but are we really being able to touch the core issue of social communication and how to take them forward is what is thing. And today, to address this issue, we have two very important speakers. One is Dr. Swapna Sebastian, who is a professor of audiology and speech pathology, and her topic is going to be on improving communication skills in children with ASD perspective. And this is very, very important, because when we talk of improving communication skills, we have to remember there are two different. I mean, improving communication skills in hearing impaired, and then I have improving communication skills in social communication. So this is the first speaker, this is Swapna Sebastian. Yeah.
Thank you.
Yes. So I think I'll introduce the next speaker after her speech. Is that all right? So can I call upon Dr. Swapna to take over, please?
Thank you, ma'am. Can you hear me?
Yes, can hear.
Yeah. Hi, everyone. The topic of my presentation is improving communication skills in children with autistic spectrum disorder. So, the social communication and interaction deficits are one of the major criteria according to DSM-5 to label a child as autism spectrum disorder. And as you know, we use language not only to communicate to ourselves. There are a lot of time we communicate to ourselves to plan our things, you do a lot of mental calculations with your language. But most of the time, language is used to communicate with others around. That is mainly for social interaction. And this communication is not only always verbal, it is with the means of non-verbal as well. For example, you are in a classroom where you have a very strict teacher. The students know how to communicate with each other through their body language, through the expressions, through the eye blink. So there are a lot of things that we share through body language as well, which are the ones which are totally lacking in autistic children because they are least bothered about interacting with others. Now, coming on to the difficulties with communication, there are few who are totally mute, they are totally non-verbal, and there are few who are delayed in their language acquisition. And the ones who have language, you again see certain language problems like echolalia, which is nothing but a repetition of whatever they hear, which can be immediate, delayed, or mitigated. They are very literal in understanding. They just don't understand sarcasm, they don't understand jokes, metaphors. You say it's raining cats and dogs, they look for cats and dogs. They have severe problems with pronouns. They have difficulty with I, we, he, she, you. So I'll be dealing a little bit about the auditory manifestations of autistic children as well. So if you look at the auditory problems that you see in autistic children, you see something called hyperacusis, where they just can't tolerate certain sounds. You see them closing their ears and walking around. You may see hypoacusis. it is not that they don't hear, they just don't bother about what they hear. You call them, you scream at them, they don't listen to you, but no, they hear the advertisement of something which they like in a very soft sound, they will respond to it. Some of them show auditory processing disorder and some show hearing loss as well. Now, coming on to the hearing loss part, 5.3% of children with hearing loss can have autism. So the people who see children with hearing loss are usually the ENTs, and they hardly have any training to pick up autistic children. So all that they look into is the ears and the audiogram reports. And the minute they find that it is a profound hearing loss, they don't look into the behavioral aspects. No, they think all the behavioral problems that you see with these children they attribute it to hearing loss. And this is where it's very important that the assessment and management should include a developmental pediatrics team, including a developmental pediatrician, a speech pathologist, a psychologist. It's very important that the minute you see a child with profound hearing loss, the ENTs will immediately counsel the parents for a cochlear implant. Autistic spectrum disorder is not a contraindication for cochlear implant, but it is very important that you do a proper assessment by a multidisciplinary team to look at the behavioral issues. You also need to do a parental counseling regarding the expectations, because even an autistic child with normal hearing need not speak always. So a parent has to spend lakhs of rupees, and in an Indian scenario, most of the time the parent will have to spend money selling all the things that they have, expecting that the child will speak. So you need to make the parents understand that the cochlear implant will help them in hearing better, but there is no assurance that the child will develop normal language. And you also need to be a little careful whether the child is going to accept the cochlear implant, because some of them may just throw it off. So it will be always better that you have an observational period with a hearing aid, seeing how the child is going to manage with it before you go in for a cochlear implant. The next auditory problem that we see is auditory processing disorder. To make you understand what is auditory processing disorder, I'll just compare it with an analogy. Just imagine you are in a party. There is a lot of noise going around. There is so much of people speaking around, the noise of the plates around, the shouting around, the music around, the doors slamming. And in between all these things, your friend is trying to speak to you, and you try your best to concentrate on the speech of your friend so that you can answer to her. And you will also have to look at her face to get the visual cues so that you can really concentrate on what she's saying in spite of all this noise. For an young adult, it may not be very difficult to carry out a conversation in this scenario. But as you start growing older, you may find it little difficult to have a conversation in such an environment. This is what happens in a person with auditory processing disorder. For a child with auditory processing disorder, a normal environment will be similar to what I explained just now. So the fan sound, the little sounds that are around will be too much annoying for him. And when he has to make a conversation in between this, it is really difficult. So these are the behavioral characteristics of a child with auditory processing disorder. They may have difficulty in localizing the sound. They just can't make out from where the sound is coming, and difficulty in understanding what you're speaking when there is noise around. When you speak very fast, they find it very difficult to understand you, and they take longer responses to give a response to your communication. And they are sometimes inappropriate or inconsistent in their response. They are very, very poor attention span, and they get easily distracted, and they cannot follow complex commands. And there are no gold standards to measure these behaviors. Now, there are a few studies which have started looking into the auditory manifestations, and some of them shows that there are abnormalities in the autoacoustic emissions that are picked up from the outer hair cells of these children. So just to make you understand what is autoacoustic, most of you must be familiar with it because it is being used for neonatal screening. So autoacoustic emission basically checks the sound that is emitted from the outer hair cells. So as you know, when a sound enters, the tympanic membrane will vibrate, the vibrations are passed on to the ossicles and the stapes will vibrate, and there is a traveling wave created inside your cochlea. And depending upon the frequency of the sound that is coming, different areas of the basilar membrane will get vibrated. And because of these vibrations, the inner hair cells and the outer hair cells will get stimulated. The inner hair cells has got more of afferent fiber, so it takes a nerve impulses towards the brain, whereas the outer hair cells have got more of efferent connections. So the outer hair cells, a major function is it has got electromotile capacity. So it will contract and relax because of this electromotility. And when this contraction and relaxation takes place, the traveling wave is enhanced, and this will actually amplify the sounds that are coming. So when this electromotile contraction and relaxation takes place, the outer hair cells produce a sound which can be picked up, which are known as the autoacoustic emissions. Now, because of this efferent activity, in a normal person, they know which are the sounds that needs to get amplified and which are the noises that doesn't need amplification. So this will help in a good signal to noise ratio, and you can even understand what is being spoken when there is a noise around. But this OAEs are found to be abnormal in autistic children, not all of them, few of them. And this may be the reason for the auditory processing problems that is shown by these children. There are also certain studies which speaks about cortical potentials being abnormal. And it's really difficult. We have tried doing cortical potentials on these autistic, and it's really difficult to do it because you cannot sedate these children because these are potentials which needs to be done when they are awake. And when they are awake, they just don't relax and sit, and it's really difficult to do it. And coming on to the management of these auditory manifestations, children with hyperacusis, assistive listening devices can help. Assistive listening devices are devices which are worn around the neck. So basically what it does is it will amplify the speech signals, and it will subside or it will attenuate the noise around so that the signal to noise ratio is good and the child can really understand what you're speaking. The next thing is auditory integration training. Auditory integration training is an intensive listening program where the frequencies to which the child is hypersensitive are filtered, and the frequencies which the child is hyposensitive is amplified, and the training is given for 10 days. There are a lot of controversies regarding how effective these techniques are. And the next thing that you can do is desensitization of these sounds which the child is scared of. Now, your therapy techniques will also depend upon whether the child is an auditory learner or a visual learner. Children who have got these auditory processing problems, it's better that you give a lot of visual cues along with your therapy, whereas the ones which doesn't have, you can go ahead with your auditory therapy. And for children who have got auditory processing disorder, you can again use assistive listening devices, as I've already told. You can use auditory integration training. You can give a lot of visual support, like you let the child look into your face. You slow down your rate of speech. You can give visual aids along with your speech. And there is a software which is known as Fast Forward. The autistic children are usually children who likes playing with electronic gadgets. So this is a software where you can go to the next level only after listening to it and listening to the instructions. They have to follow the instructions. So it is mandatory that they have to listen to it. And there are different modules. It works on auditory memory, it works on auditory attention, auditory processing, auditory sequencing. And for each step to go ahead, you have to listen to the instructions and then do accordingly.
Ma'am, excuse me.
Yeah.
Yeah, you can shift to the complete presentation mode. No, we are seeing partially one.
Oh, is it?
Slide mode. Yeah. Yes, slides.
Okay.
Fantastic.
Now coming on to the therapy techniques for language development, they can basically be divided into clinician directed or child directed. The basic difference is that in a clinician directed therapy, the clinician decides what you're going to work on and what is the environment which the clinician is going to build up to for her to work on that particular goals that she has taken up. And she will also decide on what are the rewards or what are the positive reinforcement that she's going to give. So basically, you can use any of these techniques, which these are all clinician directed techniques. The first one is imitation and modeling. Even a normal child learns language imitating the people around. So imitation and modeling is basically you're going to give a model and you are making the child imitate what you're doing. And joint action routine is one where you're going to be in an environment where you have already decided on what you're going to work on, and you will make it so attractive that the child's attention, you try to get the attention of the child onto it, and then you start explaining about it, and so that the language is being stimulated. The third one is video modeling. In video modeling, you're going to show a video of a good behavior which you want the child to develop. For example, you show a teacher coming into the classroom and the children getting up and saying good morning. So you show the video and then you make the child get into the room and ask the child to do as he has seen in the video. And the next one is social narrative. Social narratives are small pictures arranged in order for you to teach a particular behavior. For example, the child has got hyperacusis. So you show the picture where a child gets into the cafeteria, it's too noisy, he cannot tolerate, and then he speaks to the person over there asking, can I move on to an area which is less noisy? So this is what you teach using a picture card, and then you take him to the cafeteria and do the same thing. Okay, and childhood apraxia may be one of the causes of totally nonverbal children. Childhood apraxia is a speech motor planning and programming disorder. To explain it a little more, you know that if you want to speak something, the air from the lungs should come up, the vocal cords should vibrate, and then your articulators need to move. For example, if I want to say my, okay, my vocal cords should move. For me to say ma, the soft palate should come down, the lips should close together, followed by opening of the lips. And for me to say ah, then my back of the tongue should move up, and to say e, the front of the tongue should move up, and everything should be happening in a sequential order at the right time. So this needs a lot of programming in the brain. The brain has to program which articulator should move for how many seconds, how, in which order. And this programming reaches your articulators and your speech system, which helps you in speaking without thinking about it. And a child with apraxia has got a problem in this programming. So they find it very difficult to have the movements for speech. And from moving from one speech sound to another speech sound is again difficult. And because of this, even if they speak, it doesn't have the melody as you and I speak. Okay, it looks very monotonous. And for children with apraxia, we usually work on oromotor skills. So oromotor skills, basically to work on the articulators, you need to have a stabilized jaw. So jaw stabilization is the first thing that we do. And you also work on the different movements of the articulators. You want the lips to move, you have the lips to be retracted, the tongue to be retracted, the tongue to be protruded, the tongue to be elevated. So for production of sounds, there is a whole lot of movements of the oral structures, which are taught through fun activities, because if you ask them to do it, they may not do it. So these are things that is done during oral motor exercises. You also give a lot of visual gesture cueing, where you teach the child to speak the speech sounds and you explain how it is produced with a lot of visual cueing. You also do a little bit of massaging to get these gestures out. And the next thing that we use is communication focus intervention. What it means is, in communication focus intervention, you are not really bothered whether the child is going to have a verbal communication. Your only aim is that the child should communicate the basic needs of the child. You are really not bothered whether it's oral form of communication. So these are called alternative augmentative communication, AACs. So the first one is picture exchange communication, PECS, which most of you must be familiar with. So the child will have a picture and the child gives a picture to the adult and the child gets whatever picture he is given, that particular thing he'll get it. So slowly he will learn to use these pictures to make sentences and communicate. And with all of these ASs, even though we start for non-verbal children, when they start using ASs, what we have found is many of them, the oral language slowly starts developing as well. And facilitated communication is one where it is seen in some children, you give a little bit of pressure at the wrist area, they start typing on a keyboard and they can start communicating faster. So that is known as facilitated communication. Communication board is a low-cost AAC where people who doesn't have much money can use it. So you are going to paste pictures of the basic needs of the child onto a board, and the child points out for the basic communication. And then you have voice output communication aids, where these are electronic gadgets where you touch the picture and it speaks for you. So the child will get an auditory feedback as well, and he is also communicating his basic needs. Now, coming on to the child-directed therapies, in child-directed therapies, when compared to the clinician-directed therapy, you are not going to plan as you did in your clinician-directed therapy. Here, you are just going to be with the child. Whatever activity the child is engaged, you are going to participate in that, and then you are slowly building up language. For example, you see a child lining up things again and again. So you also start lining it up along with the child. So when the child sees that you are also doing the same thing, he will look at you thinking that there is something we both are sharing together. So slowly you get into the world of the child, and then you start explaining, oh, you are lining up. Is that yellow one? Shall I give you another one? Shall I give you the red one? Are you lining up the train or are you lining up the aeroplane? What do you want? So slowly you can build up vocabulary, but you are not going to be very strict about what you're going to work on. And you are not going to plan ahead. It doesn't mean that you are not working on the language. You are getting into the activity of the child and explaining what the child is doing and slowly building up vocabulary along with that. To sum up, there is no single approach which is best for all the children or for the same child over a period of time. So you need to select the strategies based on the child's need at a given stage. So it depends upon whether you are going to teach a new skill or you are going to generalize a skill that the child has already learned. So these are some of the references. Thank you.
Yes. Thank you very much, Dr. Swapna. It was a very interesting and lucid presentation. And thank you for bringing out the concerns, the hearing concerns, which are associated with the communication problem. And many of the behaviors that we see is basically because of defect in sensory modulation. And I think the music therapy that Vibrosummit is coming is trying to address this sensory, to modulate the sensory inputs. And it is something akin to auditory and modulation therapy. Well, I think I will ask the next speaker and then go on to further questions and answers and comments on your talk.
Madam, can you stop sharing, Madam? Swapna, Madam.
Yeah, sure.
Yeah, yes, Madam.
Good evening.
May I now invite Dr. Ashwini. So our next speaker today is Dr. Ashwini Kulkarni, and she is a fellow in developmental behavioral pediatrics, and she is the consultant pediatrician of Small Steps CDC in Pune, and she will be addressing the deficits in social communication and social interaction in children with ASD. And wherever we go, we find that these children are being a misfit. And so I'd love to listen to Dr. Ashwini, who's going to break the silence now, that where is the problem and where we need to intervene. So over to you, Dr. Kulkarni.
Good evening, everyone. It's my really pleasure and honor to be on this platform and to share my views with Sabina ma'am and Swapna ma'am, Babu George sir, and all the team with Vibronica. Actually, the topic is very interesting, how actually we are going to break the silence. Uma Shankar sir, can you just make me able to share my screen?
Yeah, yes, madam. Yes, you can go ahead, madam.
I'm not able to actually share the screen.
Vyas, can you help her?
Yeah, one moment. I'll make her a score.
Yeah. Specifically in today's topic, sir has given me the, thank you very much. Just 1 second. There are two things which we are looking at. The one is just 1 minute. Are you able to share this? Able to see the screen? No, no.
Yes, ma'am. It's clear.
Yes.
No, but the presentation you are able to see.
Yeah, we can see the presentation.
Yes.
We can see the
Yeah. Okay. Thank you.
Actually, we can see.
Yeah. So basically there are two things. We are looking at social communication and social interaction. When we are seeing at both the things, communication can be just as ma'am said, it from non-verbal to verbal. It can be need-based, or most of the children can have need-based communication, that they can ask you their needs about feeding, about toilet training, about something what they want. And second is interaction. Interaction is where actually you are speaking, the child is reciprocating, maybe the child is initiating the talk and you are putting into the talk, and the loop is going on. So both the things are really becoming actually they are very tough for these children, because if we go for as we know, the deficits in the social communication are the core feature since the inception of the term autism. And the clinical features depend upon, whenever we are keeping in mind these two things, we need to keep the three important things in our mind. And we should understand what is the child's age, what is the child's cognition or understanding capacity, the level or the severity of symptoms, or how the child's functionality is, because the child's social communication and interaction is going to be dependent on these three important facets. As madam has explained us, the spectrum of this interaction increases. Initially they are the caretaker, the family members, maybe the sibling, maybe the extended family members, the therapist. Then it becomes a small group, playmates, or maybe the daycare, and then it becomes going to a bigger group, more than 5 children, more than 10 children. For older children, we are looking at, it is maybe the sheltered workshops, maybe the training, or maybe the proper participation in the community. So the span of participation is increasing as the age advances. Now, typically, the clinical features, Swapna madam has made the job very easy. She has explained us how heterogeneity between the clinical features. And I think post-COVID, all pediatricians at all levels, we have seen that there is a tremendous rise in the autism mimic symptoms. So usually the children who we are able to see as a pediatrician first are commonly the children who are in the toddler age group. So here I would see in the toddler age group, the clinical presentations are mainly before pre-linguistic skills, having poor joint attention, maybe non-verbal skills, or maybe the gestural skills are lacking in these children, and predominantly parents will tell us the child is not looking at us and the child is having in his own world. The child is having solitary play. For a bigger children, for example, for a children, I'm just saying in deficits in 2-3 minutes, 2-3 manners. For the children who are bigger, who have been started with the therapies early, who has received early intervention, maybe who are attending a group, the children will have issues with speech. For example, what? The child may have echolalia. The child may answer to the questions whom he has been trained. For example, he may answer, what is your name? But he may not answer what you have done in the morning. So this is what the children at this age, they may have single words. So they will just utter the word ball. They may have only need-based communication. Again, the attention span, what is a continuous complaint throughout almost all the lifespan, which, or the children we are seeing at various ages, is they are not paying attention to the person. So this is what the core feature where we need to start quite early and focus throughout our intervention plan and throughout our goals. And participation in group. Maybe the child may just finish the activity and will get up. The child is interested only in activity-based learning. The child may not sit for the complete turn taking, for the complete circle time. And for bigger children, for example, these children specifically, for the children who are high functioning or relatively maintained language or who are relatively verbal, they have deficits in comprehension, poor inference. As Swapna madam has told us, they will not understand, they will take the literal meaning of the language, but they do understand, and there is difficulty in understanding the gestural views also, your facial emotions. So what you say one word with a different facial expressions, they may have difficulty in understanding that and staying on topic. So this is what all this spectrum we need to keep in mind, and how we can help these children, how realistic expectations need to be taken from these children. That is how we are going to break the silence. It is not, as madam said, it is not going to be expectations are the same for all the children. Now just 2 seconds, why, on which factors the social behavior is dependent on. As we know, there is a proper social communication network in the brain and all these different areas. I'm not going into the detail of the each brain area, its function, but it is everything related with your emotional understanding, first giving the perception, then attention, then the memory and the motivation. Where the children are lacking is the motivation to speak, because the first thing is attention, and perception is difficult in these children. And till the research, we have known that it has neuropathological, neurobiological basis, where actually the different researchers, the pharmaceutical companies, all the are working to find out specific. Can we get a specific biomarker? Can we get a specific amino acid or a specific neurotransmitter imbalance in these children? Currently, all the research is showing that there is heterogeneity, or there is a difference between all these children. Definitely, there are problems in the brain networking where they have the networking, the short, you can say the short circuits, and you can say the long circuits, where the integration between the long circuits is difficult, or it is problematic, or it is imbalanced in these children. And currently, oxytocin has been shown a very promising effect, or we can say that it has shown a specific hormone in social interaction. And the clinical trials are mostly right now has been done mostly in adults. In children, they are going on, but it has shown some promising effect on the core feature of that social interaction. Then how we are going to break the silence is the synergy. Maybe this word, I want to use the word synergy, because we know that all the interventions, they are hodgepodge, I would say, because it is, in the first slide, I have seen that it is a lifespan where we are doing it in years. What parents think, it may be a 3-month intervention, it is a 6-month plan, I will take 3 months therapy, the problem will end, 6 months therapy. But no, here there has to be one person in between to understand and to monitor all the 4 facets, just like the 4 wheels of the car. First is the individualized needs of the child. What are the deficits in this child? What are the skill subsets which are going to increase in the child? So it is through the individualized intervention plan. How we are going to execute it is with the therapist help, it is with the parent mediated intervention. Then actually the group or school, accommodations and interventions, and the medications and monitoring. Usually what I would ask parents is to have a communication between all these four wheels of the car. If you are just working on one thing, most of the time what parent will think is that I'm taking the child to the therapist, even though I talk with my child or I don't do those exercises at home, it is okay, I'm taking my child to the therapist, but the effect will not be the way we are expecting. This is how the aim of all these interventions is to build the neuronal networking. And here we need to work together. Maybe a call to a school teacher on from your table when you're looking the child, and actually understanding what problems the teacher is facing, and how the shadow person is helping. How the many times I have seen parents where the parents tell me that madam, कोई स्कूल मेरे बच्चे को ले नहीं रहा है अभी क्योंकि मेरा बच्चा बैठता नहीं है. So it is very, and if we want a social interaction, it is a two-way. We also try to accept the child and understand and reciprocate to the child. So this is what the community adaptations or awareness, I will come on the last part, but here also we need to speak with the school teacher, and we need to find out, it depends upon the local resources again, but the word is synergy. We always, when we are treating, we need to find out and see whenever you are seeing for each visit, how we are going ahead with each point, where we are stuck, at which point we are stuck, and can we help each other. Now, the treatment principles are current and what are in research. In current, what we need to understand, there has been two questions from the audience. Do drug help these children? The one thing what we need to understand is till now, there is no core drug to understand or to help or to elevate the core features. That's why we are currently calling it as a disorder. It is not a disease. Definitely screening at early, and I do remember Shabina madam releasing the IAP pictorial what we say
Pictorial tool.
Yes, ma'am, pictorial tool, and that was so beautiful, and it was explained in gestures and in pictures so well to identify the early pointers. And I think as a pediatrician, as we know that the child starts behaving differently, the reciprocal maybe cooing, the looking at you, and everything from the first year of life, whenever you feel that the child is not being engaged in the specific, the caretaker or a person, or showing attention, all the pre-linguistic skills, they are deficient, I would urge all pediatricians to go through all the screening protocols. Just be aware of the clinical features whenever you are vaccinating or whenever you are addressing the acute illness in the child. Just make two important age appropriate developmental goals and just ask the parent, or you may look at it. So this is what at risk, picking them early and early intervention shows beautiful results. And do keep in mind that diagnosis, treatment and monitoring goes maybe hand in hand. The diagnosis may take few months, or it may span over a time, because post-COVID in the last year, we have seen many mimics where whenever you give them proper intervention, actually the children show very minimal reduction in the specific features. So don't rush into that diagnosis. So work for the skills. This is what I would say. And keep in mind, this is explaining the parents about what you're working at is very important, and counseling comes here very much a bigger role. Now, all the aim of the treatment is functionality and participation, and gradually we are working with 1:1, then in a small group and then a classroom. And in research, what the medications, the dietary changes, complementary metabolic agents, I will go in the next slides. So what the intervention plan is, best before 5 is the best. As Swapna madam has said us, it is either clinician oriented or a child oriented. Initially, where I would say is one thing, really we need to increase the child's interest in the person, because they don't have that motivation from inside. That is a core feature with them. So really giving them positive rewards. For simple example is when you are giving anything to the child or a object to the child, first keep it at your level, go at child's eye level, see whether the child looks into the objects and can give you an eye contact, and then you are giving the child. This is a very simple technique. I know every one of us must be knowing that. But this is how we are actually need to work if we need to break the silence from so early age, whenever we are picking these children, at-risk children. And there we are going to need to work on pre-linguistic skills, the imitation skills, the pretend play skills, and sharing the interest. The typically proto-imperative and proto-declarative pointing that I think has all of us know where the child needs to show his interest. That thing we need to typically increase in these children. Now, the classical evidence-based therapy, ABA currently, which is showing effect, is applied behavioral analysis, because their brain is a structured brain where they find the structured plan, they learn it faster. So this is how actually the ABA, the language and social communication or the interaction, it is hand in hand. So ABA do help us to have these interactions in a better way, but ABA comes with its own limitations. And we know we need to understand, whenever the parents' complaint is मेरा बच्चा बोलता नहीं है, मेरा बच्चा ध्यान नहीं देता है, मेरा बच्चा स्कूल में टीचर को reply नहीं देता है, this is what a facet for social communication deficit. But you need to work. The parents' needs are different, but at the same time, your goals should be the way the trajectory goes. You need to manage the child holistically. See, please look at whether the child has feeding problem, the child has sleep issues, the child has gut issues. So all this, taking a proper child's history of throughout the day, and then addressing all the issues together. And please let the parents know that all these issues will be tackled gradually. So this is what we need to tell them. So associated conditions, if the child is not able to sit, the child is not able to speak with you, or child is not able to communicate with you. So this is where we need to actually go step by step and holistically. And the progress is very variable in all these children. Some children learn is very quickly. As I said it, age, cognition, and the severity. The child who is having a good cognitive skills, the good learning patterns, the child's age is early, and the child's symptom severity is very mild, the child is going to progress very early. The child is going to speak. Actually, the child may speak words, may respond to you, say hi, gestures very early during our therapy plans. So the hurdles, what we see, availability, duration, cost, that we know. We are getting it from all socioeconomic strata, from all different cultural backgrounds, from all rural, maybe city-based, everywhere. So how we are going to reach out with all of them? Currently, that is the main hurdle in intervention plans. And I think all of the stalwarts in this field are coming up with all home program, the parent mediated program, and everyone is working almost how we can help the parents to learn this and do it at home. So managing the difficult behaviors, what currently we face is self-talk. Equally, as the madam has said, the child has continuous self-talk. The child is in the session, but the child is in his own world talking something, he's making it aloof. So we need to understand the reasons behind the self-talk. Many times it is just, as madam has said, Sabina madam, starting from sensory issue, starting from social hesitation, up to specific interest in something, or maybe a repetitive. The child has seen 1, 2, 3, 4 in your the calendar. Typically, this is what happens with us. If we have a calendar and the child is obsessed with numbers, the child will come inside and will continuously look into the calendar and start speaking the numbers. This is how actually Swapna madam must be also facing the same issue. See, number plates, alphabets, the child who is obsessed with this, the child will continuously talk about that. So there actually we need to go ahead with the child's interest, then into the people and into the activity actually which we are involved. Now the acceptance level, it happens in years for the parents, for the teachers. Currently associated medical syndromes and the heterogeneity, as I said. So how we are going to deal with it? The first is keep achievable and simple goals. Give parents a 1 monthly goal or a 2 monthly goal or a 3 monthly goal. That is what goes slow. Go first approach on the daily life skills. This is because it is the most time consuming for a 3-year-old child or a 5-year-old child, as madam said, oromotor skills. The child is not eating, the child is on liquid feeds, and the mother is throughout the day, just how I should feed the enough calories to my child. So first, look into from all your facets. Even though our goal is social deficit, we are working with the child's self-help skills initially, since beginning. Let me know that this will make a child very much independent when the child goes to the school. When the child has that confidence, I can share my toilet need to my teacher. This is what we want. And this is how the social interaction is going to start. Involve the family members during your visits with the child, with your ask grandfather, grandmother, ask them to come. Let them understand, let them attend the therapy sessions, let them speak with the therapist, because most of the time the acceptance starts from everywhere. The parents don't disclose the diagnosis. The parent don't, many times they don't tell at home what has happened. They are getting fear of, I will be getting segregated or there will be blaming game. So here involve the family members and be a skill-based thing. Assign responsibilities, a small responsibility. When you say, when a doctor says to something, yes, आप उसको इस 10 मिनट के लिए लेके जा सकते हैं, इसको ये 15 मिनट के लिए आप definitely you go and enjoy your time with your child in the park. If you say this to a father, the child will happily do that. But this sometimes the father knows, but the father is not able to do from all the responsibilities. So this is assign smaller responsibilities. And this is very important, what transparency between the therapist, a doctor and parents. Transparency is what I feel. I call the therapist and I speak with her, madam, aapko kya lag raha hai? Kahan pe you are getting difficulties? Is it the same where I am thinking? Are you on the same page? Are we on the same page? And if we are really on the same page, miracles happen in these children. This is what I would say. Parent-mediated intervention, right now, it is the goal for all the therapy plans. It is real-life training. The parent taking a father to the shopkeeper and asking for milk. This is how social interaction is going to start from real-life training. Parent can teach comprehensive skills. But here, we need to tell parents, it is not important that your child should say ball. It is okay if the child uses the gesture and takes the back to the shopkeeper. Behavioral handling, everything. And as madam said, the social stories and sibling interaction. If we have a typically developing child or a sibling, this is a blessing. So this is a social storytelling, all this. So initially focus on imitation, pretend, and then on the exploration. That, as madam said, Swapna madam, you have know the child's interest and now explore the play. You know the child is only making up the toy line, take the train to some petrol tank or fill it something. So this is how the floor time starts. This is how the parent is going to do at home. And really you need to be in the child's world. Sometimes I ask parents, आप उस साइड पे गए हैं क्या कभी? आपने सोचा है क्या कभी कि बच्चे को क्या लग रहा होगा? So आप मराठी बोलने वाले हो, and if you go to the Germany, in a bigger place, or you go to a bigger some metro station in somewhere in UK, what you will feel? The same way the child is going to feel. So this is how going at the child's end and start from these basics. Now, what are the problems or hurdles? Parental stress, quality of life, as we know all these things, consistency in years. And we need a lot of local adaptations for this, and the acceptance. Some behaviors will stay. For example, for social deficit, the child is going to come into our clinic and the child will look at the fan first and then the child will look at me. I'm okay with it. For me, if I say I'm okay with it, I'm okay with this social interaction, I have given the child space to see his restriction. But if that restriction, looking at the fan, is continuously getting intervene and stopping the child from learning, I'm really going to act for that. So this is how, let the parents know that it cannot completely stop. The child cannot completely stop. Don't look at it. Parents will say, don't look at the fan, look at the doctor. So it is okay. The child is looking at the fan. At the next point, the child is now familiar with you. You give him, you go at his level, the child is going to say hi to you. That is okay for me. And I would ask opinion of Shabina ma'am also, Swapna ma'am also, how we can go ahead with this. So let the parents understand, accept that some behaviors are going to stay, and how to handle the difficult behaviors. It is not, I know it is not a domain of today's talk, but this is how a hurdle in social deficit and social communication. If for this we start from early, gradually, looking around the sensory issues, the behavioral part, with the appropriate use of medication, with involving all teacher and everything, we can control it down to a lot. Now, how the school readiness? This is how most of the time for high functioning children, the peer interaction into a group and visual schedules have worked. And structured predicted training helps all these children. As madam said, video modeling, peer feedback, peer imitation. So the buddy, I usually ask parents for higher functioning, get somebody in the school. And this is how actually reciprocity, what interaction and communication is reciprocity. At least let the child first have one friend where he is reciprocating. The friend is asking, the child is saying, the friend is sharing his tiffin, the child is also sharing his tiffin. So this is how all the small things will start. So this is how the school small group will work. But this is, most of the studies are done in children with high functioning autism. Now, school participation, I would rather say that it depends upon the local native place options. At some places, there will not be option of spatial schools, shadow teachers, just there will be Anganwadi. So there, start from that place and see local available resources. Using sensory toys, calming techniques. For example, if the child can have some smell, and it is okay, the child is calm. So the teacher can have those things with her. If you feel the child is restless, give one drop of some whatever, suppose for example, sanitizer, or maybe the child smells and the child is calm. Many a times, squeezy toys, all these things, but it depends upon the child. So calming techniques. So I asked mother, how simply, what you feel, how your child calms down, by what? Many times music therapy. Now most of the parents say that वो music बहुत सुनता है मैडम, उसको words नहीं समझ में आते. He feels those words by himself, but the child understands the tune completely. So really music has helped these children, it makes them calm. So using those techniques, and as madam said, regarding those noise sensitivity, noise cancelling earphones, plugs. So this, and managing about the difficult behaviors, training the teachers, maybe the caretakers. So this is how, for example, I will give an example here for a child who is non-verbal, a 12-year-old child with a severe symptoms of autism, completely non-verbal child. The child is attending a special school where the child the teacher has shared the next child's tiffin with this child to understand, to show the sharing, and you also share. तो एक बार उस बच्चे को वो टिफिन शेयर किया, the next time the child has repeatedly asking from the next day about the same tiffin of that child. So this is how, and if you don't give to the other child's tiffin, the child will show tantrums, the child will hit. Now you know that here, this has a specific antecedent for that. You need to manage that antecedent. There is no specifically need for the medicine for this aggression currently. So how you are going to manage the antecedent? But the teacher was wild enough to understand. Now what she did is that whenever the next child comes, she removes the child's tiffin, she keeps it aside, और वो सिर्फ बाकी का बैग रख देती है. ये आता है, ओपन करता है, इसमें टिफिन नहीं दिखाई देता है, वो शांत बैठता है. So this is how actually managing the difficult behaviors and real videos and real life scenarios, actually making them taking in a smaller groups into that. The next thing is school. Now the important point about the medication. Now where medications are indicated, definitely. Clear-cut guidelines are currently there with IAP. Irritability, aggression, hyperactivity in attention, which is not responding to the behavioral measures, maybe sleep disturbances, constipation, which are not addressing to our initial measures. So, and in bigger children, for anxiety and specific obsessive or compulsive behaviors. In bigger children, maybe in some high functioning children also, they can have this OCD-like pattern. So there, this is a group of drugs, starting from risperidone to anticonvulsants with a specific scheduled use. What we are going to see is the judicial use. First, it should be known that it should be prescribed by a professional, medical professional, maybe a pediatrician, a DP, neurologist, or a psychiatrist who is learned and trained in that. Sometimes what we see that someone starts giving the medicine and parents may continue it for a few months or for years without looking. We know that risperidone has a problem with metabolic disturbance. It can create obesity. It can have metabolic. So are you actually doing parent counseling before you starting the medication? Are you targeting the drug for which behavior? So first go with this, that are you targeting some behavior, and is your drug what you're looking at is going to be useful for that behavior? Discuss the use, the side effects, the duration, and the monitoring purpose, everything with the parents. And then with taking them into your whole, this is what transparency is. And then you start with the medication. The response with all the drugs is different. This is again a hitch. In all children, risperidone will not act. So this is again a hitch which needs to be, so I would say IAP guidelines would help us to that. And it varies according to the age group. Now, the next is what research. Two questions are there. Does madam nutraceuticals help, or does all these? So currently, I have decided, I have framed it in two parts. Discuss with parents, some there is possible benefit, like for example, diet, GFCF diet. So say it's a very tricky thing where actually you need to counsel parents and it is a true gluten sensitivity or no, because the diet itself comes with its own hazards. How much duration? Just किसी ने बताया, किसी ने किया, उसको आया, इसलिए मैंने 6 महीने करके देखा, 3 महीने करके देखा, ऐसे नहीं है. What exactly needs to be done? So take this judgment with a proper trained medical person with this, and discuss the parents with all the facets of this. Currently, it is not a recommendation in the evidence-based. Unknown, there's oscillation, hyperbaric, all these things have a proposed hypothesis how they work, but they come with their own potential risk and side effects. Here, as madam said, regarding the cochlear implant, all these issues first discuss out with the parents gradually, may not be in the first meeting, but whenever the parents do come, because they keep on reading, they keep on visiting everyone. Whenever they are waiting outside, the parents are discussing among themselves. So first, parents ask, do you have any queries regarding all these issues? And then you address it with very aptly, but currently they are not recommended. With low risk, possible benefit, music therapy, melatonin, oxytocin, pet therapy, yoga, they are actually showing results in some children. Unknown, as madam said, there are various opinions regarding auditory integration and nutritional supplements again. So definitely we need to maintain their daily dietary patterns with iron, with D3. This is all. And omega supplementation comes in a dietary facet, the dietary intervention. So this is how limited role, where currently it is not going to change the game of the disorder. Now, the last is community participation. This is how a beautiful picture which someone shared from our group is this is a bath. Bath is a place in UK. And what they have said, we have proudly autism friendly. This touched me a lot. And see what they have written. So this is creating awareness among ourselves, between all the community. We need to look them like all of us, maybe the accommodations, the acceptance and inclusion, which is all of everyone's real wish is. So this is how social, so breaking the silence starts from early age, screening intervention, helping the parents, judicial use of medication, keeping the realistic goals, go stepwise. It is okay. Some children may go only for need-based, some may be single words, some may answer to what you have said, but some may actually go into the communication loop, but they may stop the communication. वो बताएंगे, आपके साथ बात करेंगे. For real, I can give you for the verbal children, agar you can give them key pointers. For example, if you want them to explain about the school, you give them keywords, 2-3 keywords, and then they can frame and they can tell you. So using augmentative devices, as madam has said, it helps these children. Using visual schedule reduces a lot of the behavioral problems, and synergy between parents, medical professional, the therapist and the school, and community inclusion from all of us. So this is how my thought processes would be. And now every word or sound uttered is important communication, that to all the quiet moments too. So till the time, thank you for patient listening. I may have exceeded the time, and once I start speaking, it really becomes for me to control myself. But thank you very much for patient listening. And now we will be open for questions. Thank you, everyone. Yeah.
Thank you, Dr. Ashwani, for your wonderful presentation.
Yeah.
And you have talked about entire problems of autism and how to handle and how to manage. Now, few things I just wanted to say was one thing, very good thing that you said was that the motivation to speak must be there. So now all along we were talking about deficits. The child cannot do this, child cannot do this, child is having this, child is having that. But let us all, first of all, focus on how is the child wanting to communicate. That is what our assessment has to be. There is no such thing called no communication and communication deficits. The child is always wanting to communicate. So, first of all, we have to always try to find out how the child is communicating, and then we build up on that communication. Then another point that we need to is about the assessment. Now, we know that early intervention has started and child is improved. Okay, he's beginning to say bye, he's doing imitation, he's doing this, but the fact is that how much is the level? Because development and the facets of social communication is so wide. Now, how will you tell the parent how much of the development has covered? What level have this child reached? So then again, you will find the same child is singing away, but cannot talk. And so now again comes what type of social communication again is developing in this child. So again, that how much is the social adaptation the child is having? So unless all of us, we have to always try to evaluate the social communication bit. It is not that the child is having a deficit and we are going to do this for this deficit. The child is communicating. And then again, this wonderful thing that you said, that the child's motivation to speak has to be first of all assessed. The child's understanding of the other person. Who is the other person sitting next to me? Who is the other person opposite me? And how can that loop of conversation actually? So to develop this, it is not something that you do at 4 years or 5 years or 6 years. it will never ever develop, because in my whole career I have seen that it has not developed. And even now we talk of the residual effects are still remaining in these children. So now it is for us to all rise and to address it as early as possible, as 2 years of age, because that is the age the child is actually non-verbally communicating with us. And that is the eyes that we need to have. Even some like cry. When you are born, you cry. Thereafter, the cry becomes different stages. Can we catch the child at that time? You see? So now we have to keep our eyes open, that as early as that, if we can catch them, then in that case, the stimulation that we do then covers up. Communication does not mean to say it is speech. Speech is sound. And all children of them, they come with sounds. They will say ABCD, 1, 2, 3, this, that, and this need. Then unless it is along with the, combined with the emotion, which you have mentioned, Ashwani, that unless this combination takes place, then even the tone of the voice is not going to change and the loop interaction is not going to happen. So these are the few issues actually you really need to work on it. And the behavior, the management is, of course, as you have mentioned, all these are there. In paper, it is very good. But when you work with the child, it is difficult. Then, and it is individualized for every child. And it is individualized again for every developmental age. So all this has to be managed, because the child could be having a problem now. And we have managed the child and the child is okay. But after a few months, starts having another problem. So remember, it is a developmental problem. All problems will continue to grow as in normal children. Children with ASD are not different. They have the same developmental the stages they go through. And then because it is not addressed, their developmental track has deviated. And how much are the parents responsible for it? Also, we have to find out. Because this motivation to speak probably has much been suppressed, because the needs have been given so much by the parents that the simple thing to ask, Ma, ye chahiye. The moment I do something is done, it is provided. So to ask is nothing. So these are issues we have to, and I want that the stimulation should be to find out what we need to do as early as possible, keep our mind open. And there was a question, I think, which I saw, can pediatricians work? Yes, pediatricians can work. If the ratio is 1:58, now tell me the special educators are around, I think 1.5 lakhs to a population of so much of ASD. So there is no ratio. It does not require a special intervention. We were always talking of a multidisciplinary intervention. But the fact is that what I appreciate, Ashwani, you brought out, it is the collaborative. Unless that is done, the application of what is learned is not there, and the child does not grow in a holistic pattern. So I hope, I know it's taking a long time. So I'm very happy to hear both of you and to take all your inputs. And so these things. And another thing is that you talked about the parent training programs, that now let us all try to find out naturalistic teaching. Because what hurts me, because I have started my work with autism, and I think in that I brought this nationwide. I brought it in the Indian Academy in 2007 as a national convener. I brought it to the entire nation. And what hurts me is that the moment his child is defective, oh, you have to go to the specialist, you have to go to the therapist and go one-to-one. And then comes the child becomes instructional. The child's freedom is lost. And let us all give the child's freedom of growth, the 2-year freedom, the 3-year freedom, and then make every child responsible for his own growth by what Dr. Swapna Sebastian said, child-directed management. So thank you very much. It has been very, very interesting, and thank you for giving me this opportunity and to be with you. So any other questions today?
Madam, we do have a few questions.
Okay, let's see.
Um,
Fine.
The doctor name is not revealed. How effective are the drugs and nutraceuticals in
And
autism?
nutraceuticals and autism. Yeah. You see now. First thing, drugs. There are no specific drugs that cure autism. That is the first line. Next is that we, yes.
The next question is, should general pediatrician
Yes,
treat autism patients?
I just want to, I have a little more to say about the drugs. Number one is there is no specific drugs, but sometimes we need to give drugs if you find that the child is aggressive and that aggressiveness is actually hampering the functionality of the child. That is the time you are going to give. But now we have seen risperidone being used rampantly, but not understanding that it is when the child is actually not being able to, it is causing, because for some chemical changes, this child could be behaving in such a way and being so disturbed. In that case, probably we need to give some calmers, and risperidone is one, and ariprazole has come up. And then we find again, methylphenidate has been mentioned by Dr. Ashwani. Now, methylphenidate also, we find all these children of autism are hyperactive, but the fact is that we find that methylphenidate does not work in the same way if it is a pure case of attention deficit hyperactivity disorder. So the hyperactivity is not because of chemical change. It is partly, maybe, we do not know. Secondly, it could be due to hyperacusis, as Dr. Sapna has said. It's the hearing difficulty. Third, it is the expression problem. And hence, you find that there's no energy released from this child. The child is hyperactive, and that is the way the child is communicating with you. So hyperactivity here is a communication. So, and then comes the nutraceuticals. Now, we see that omega-3 fatty acids. Well, individually, we find that vitamin D, omega-3 fatty acid, vitamin A, all these are actually, it helps calcium, magnesium, all it works with the nervous system. But the fact that specifically we do not know whether it helps in the cure. But the fact is that since we know that omega-3 fatty acids does access stimulation and sphingomyelin formation, and also this could be assisting the child for transmission of information from one nerve cell to another. So we do not have evidence-based, but yet we do find that it does, when you give these, they get stimulated. And so with L-carnosine also, because of the stimulation of the BDNF factor, we do find that there is some stimulation does take place. This is what has been my experience. Next.
Madam, the next question is Dr. Darshana Vora from Ahmedabad wants to know what strategy can you suggest to reduce echolalia?
Yes, echolalia. I think when Dr. Sapna is here, I will direct this question to Dr. Sapna regarding how would you manage echolalia.
Yeah, echolalia, you need to understand why the child is having an echolalia. Most of the time, the child may be trying to communicate his needs. So it is better not to stop the echolalia, but to change the pattern of echolalia. For example, the child says, "Do you want milk?" The child may be actually meaning, "I want milk." So you need to teach the appropriate pronouns for him. It may be a problem with the pronouns. It may be a problem with the use of interrogatives. So you need to modify the echolalia and make it more meaningful rather than making them stop echolalia.
Thank you.
I have a small input regarding echolalia. Most of the time it happens that the child may not be able to frame the answer as what madam has said. So the child may not say, "I want milk." The child is not able to frame the answer. So most of the time, that times also echolalia happens as the child's language development starts and how the child starts giving an answer, start and stop. So this is how the child gradually stops echolalia. So this is how many a times the child is not able to frame the answer or may not know the answer. You have asked him a question, what did you eat in the morning? He is not able to frame the answer. That time also, most of the time, echolalia will happen, and that improves with RR intervention plan.
So may I just add to this? Echolalia actually is a stage of development of language development. So that means the child has been in, now you know that first of all he was not speaking, then he has begun to pick up the words, they say what you say. But another thing that plays in the pronoun reversal that takes place, if he says Kabir wants to drink milk, so it's the mother who is saying, Kabir, you want to drink milk? Then the child picks up that phrase. This is the phrase picks up that Kabir wants to drink milk. So now the question is why this has happened. So one explanation that has been given is that the self of the child, it is very strange phenomena. Autism is all self-related. The word autism, auto, is coming from self. But the fact is that, but the child, again, and cannot address the child herself or himself as I. So put out one thing, that our self is two forms. It is an objective form and subjective. So when it is child cannot address himself in a subjective form, so the child cannot say I. So he addresses him in an objective form, and hence he uses the word, uses his full name, and copies whatever the other mother is saying. So this is another explanation. And management, of course, one way that I manage is that in this case, there should be always two people. You need to ask a question. You should, before that echolalia occurs, then the input of the answer should be given from the backside. And so that the child hears the last phrase and says the last. So that way, probably the cycle of echolalia can be. This is, I'm talking through my experience. I do not know if Sapna agrees to this. Yeah. Okay, so any other questions?
Yes, madam. A couple of more. Dr. Riaz Ahmed wants to know what are the earliest signs to pick up autism?
Earliest signs, very good, very good. First early sign is, you see, now if the child, is the child looking at you when you are looking at the child? But at that point, most of the children actually, if you ask that question, they will say that 3 months, 4 months, the child is looking at the mom, and then you find that when the child is sitting up, when you are doing this to the child, does the child raise the arms? So this is the first sign that, oh, some interaction is taking place. The child could be smiling, and is the child smiling in return with the mother? So these are actually the first signs that we need to, is it reciprocal? Smiling is going on? Is the child is coming up to you in anticipation? Then comes by 8, 9 months, is the child raising the hand and showing? And then or is the child trying to throw something and trying to create a triadic interaction with you? So these are some of the sub signs of communication that you have to detect in the first year. So now it has not been established totally that if these are the signs, but if these signs are missing, these are the children that needs to be really followed up to the age of 2 years, and intense follow-up must be done. And then if you have seen some deviations in these items that I have said, stimulation process must start from here. So this is the role of a pediatrician, to catch things in the most critical period and development stages of life. That is what you are. You don't think of a 4-year-old and a 6-year-old and you want to manage autism. Well, you can, you still can do it. But the fact is that you have missed all these indications in your well-being clinic. That is the responsibility that we pediatricians must now take, that how many we have missed, because they have already shown these signs early, actually. Okay, next.
Madam, Dr. Chitra Shankar from Bangalore
Yes.
wants to know how is CAPD diagnosed?
Yeah, CAPD is what is it standing for? Chitra?
Chitra Shankar from Bangalore, madam.
Yeah. What's
auditory processing disorder.
Auditory processing or central auditory processing? Yeah. Yeah, that's again probably I will have to ask Dr. Swapna.
There are tests which can be used to diagnose central auditory processing disorder. You have tests for peripheral hearing testing. You have brainstem evoked response audiometry, which is normal. But when you get an abnormal cortical response audiometry, that is one way to look at it. There are speech perception tests also present, which can be used, but none of these tests can be used in autistics because of their behavioral issues. So it's very difficult to diagnose these children objectively because they won't sit calm. You can only diagnose based on their behavioral patterns.
Yeah, it is basically behavioral patterns, and when we find that the child is listening to you once and then not listening to at times, because they are so interest driven again. That is also a factor that you have to remember in auditory processing, because they're very interest driven. So it is what interests them, they will listen, and what doesn't interest them, they won't listen. So, so it's difficult unless this cortical assessment is done, potentials are done. I think it is difficult to assess auditory processing.
Thank you, madam. We have one last question from Dr. Joshi Anand Karketa. He wants to know any special diet that can be recommended.
First thing is that I think there is no special diet. No special diet. Initially, it was thought probably it was casein sensitivity, it was gluten sensitivity, leaky gut. All these molecules are now passing through the gut, and then it crosses the blood-brain barrier and is causing stimulation. But now it has been said that there is no, if the child could, specifically if you detect that there is some gluten allergy, then of course you will have to put him away from gluten allergy. If it's casein allergy, you have to, but that has to be totally identified. There is no food as such specifically that help in the a good balanced diet. What we want is the child to have a good balanced diet. This is a very, very wonderful question I think you have put up, because food history must be taken very well in these children, because we find that the child has food sensitivity, texture sensitivity, and so hence in the transition difficulties. So this limits the child having a balanced diet. And so you must take, and this is a very good question that you have raised, but you must remember that there is no superfood. There is no superfood for the brain. You have to have a good balanced diet, and that is going to help. Like a flaxseed and all that, of course, contains omega-3 fatty acids. So many of them in the older age group, they do take a lot of flax seeds that keeps the memory up. And okay, so I hope you've enjoyed the session, and it was informative.
Thank you very much, madam. Thank you, and I now take this opportunity to request Mr. Jyoti Kumar, my colleague, to propose a vote of thanks for this session. Over to you, Mr. Jyoti Kumar.
This is Jyoti Kumar from Kepler, Veronica Division, GMC. I indeed thank the speaker and professor of audiology and speech pathology, Dr. Swapna Saraswin, for sharing her experience in improving
Mr. Douglas? Mr. Douglas, are you there?
Yes, sir. Yes, sir. Yes, sir. I'm here.
I think we have lost Mr. Jyoti Kumar. Can you just do
Yes,
the
sir.
honors?
Yes, sir. Good evening, everyone. I thank the speaker and the professor of audiology and speech pathology, Dr. Swapna Sebastian, for sharing his awesome presentation in improving the communication skill in children with the AIDS. Thank you so much, madam. I thank our another speaker, Dr. Ashwini Kulkarni, consultant development through her presentation on deficit in social communication and social interaction in children with AIDS. Thank you, madam. I thank our honorable chairperson, Dr. Shabina Ahmed, the past president IAP chapter growth, development and behavior, for accepting to be here as a chairperson. Thank you, ma'am. I thank Dr. Babu George for bringing these good speakers and the eminent chairperson into this forum. Thank you, doctor. I thank all the audience for your active participation in this third series of Autism Summit webinar that we have planned for this year. Once again, I thank everyone who present here and I remain. Thank you. Good night.
Thank you.
Thank you, Mr. Douglas. And with your permission, can we close the meeting for tonight?
1 minute. Thank you, madam. Dr. Swapna, Dr. Ashwini.
Thanks, sir.
And I
Thanks
will
for calling us, sir.
Thank you.
Okay, madam. Madam, I will send you that tool.
Please,
To
please
you.
send me. Yeah,
Okay.
please send me.
That early
That is a
detection
very
tool.
nice pictorial tool actually, which we need to put in all our OPDs, and we can use that. And I think CDC, Trivandrum, actually from CDC, we have all those screening tools, TABC and all those screening tools. Actually, we have available material with us, the Indian standardized material with us with all, but that we should start using it. It is just, we should know it and we should use it. This is how I think what madam has rightly said, picking them early will be definitely happen. Yeah, thank you very much, sir. Babu George.
Okay, madam.
Yeah.
Okay,
good night.
okay,
It's been a
bye-bye.
long time.
Bye-bye.
Thank you. Thank you all. Thank you all.
Thank you, Sapna. Thank you.
Bye, ma'am.